Much. Okay, I will try to do the best with the microphone, but I think I have a little bit problem with that too. Because when I was starting to do presentation today, I wasn't really sure about the audience. I will go, but really in the short also, with the differences to explain the disease, but really shortly, and I will try more to focus on implication. So looking at the musculoskeletal diseases in the last couple of years, they are in the top 10 conditions that actually contributing to the daily adjusted living lives, and that's really, really a lot. It's not just because of the disease itself, because, for example, also in the case that I have here, the patients with osteoarthritis, they are the patients that they are waiting for surgery, so actually their condition will be better. But generally, all the things with the sick leaves and absence of disease for healthcare, it's really, really huge when we're looking at the musculoskeletal diseases altogether. So as I mentioned, the osteoarthritis, a lot of times called wear and tear disease, because it can happen for a mechanical overuse of the joints, specifically a lot of times attacking the big joints. The surgery, a lot of times it's common there, and it can help the patients. So the actual inflammation is much lower than the rheumatoid arthritis, and that's the huge difference between these two diseases. Looking at the prevalence, worldwide really differ. Much more common in the female as most of the musculoskeletal diseases. But when we're speaking about the age, we can see it's really dramatically rising with the age, till the age of 80. But around 50 and higher, it start to be really common. Looking at the risk factors, again, when we're looking age is there, it's a lot of behavioral factors, but also the genetics, so it can happen to really different kind of the people. When we're looking at the diagnosis, again, I just want to point the age of 50 is even there on the classification criteria. So, and based on the degree after, it's different kind of the treatment. There is pharmacological treatment that can end with a surgical, and non-pharmacological treatment. Because of obesity and lifestyle, it's quite huge, the factors there. A lot of times the exercise and physical activities, different kind of psychological therapies, because it can affect the two, dietary education programs. When I look at them, a lot of them I have from research from Western and European countries. When I'm thinking Slovakia, maybe depends really on the doctors. When you end up at the patients, maybe they will try to explain you what is the role of physical activity actually there, but a lot of times the intervention are non-existing in the practice, and that's a huge problem we have, because after how we supposed to do the integrated care when in practice it doesn't work. Looking at the RA, it's more inflammation there. It's affecting more the small joints, and mostly it's disease that is incurable. So when we will think about the patients, is something that when you start to have it, the treatment just try to keep it. The goal is to achieve the remission and not actually to get fully treated. Again, when we look at the prevalence, it's much lower compared to osteoarthritis, but when we're looking at the sex ratio, again, the female are much more commonly affected. When we're looking at the age, again, older patients getting affected. So much more, here it start to actually rise even sooner, not around 50 years old, but around 40. And in Western countries, when we're looking, because again, worldwide, in some countries, actually, we've been missing data, so we don't know how bad is the thing. Many times it's not diagnosed because it's hiding behind some other disease. But when we see over half of the patients in Western country over 65 years old. So looking at the risk factors, again, it's and behavioral and the genetic factors and age is there. When we're looking at the diagnosis, actually the age is not as one of the criterion here in RA. But looking at the treatment, similar things go here with the pharmacological treatment. And when looking at the non-pharmacological treatment, it's actually even worse with osteoarthritis, because there, when we're thinking about the surgery, the patients are explained why they should do some kind of things. Here, luckily, the patients I have in database, they have dermatologists that you try to explain them that if you do not exercise, actually your pain will be even worse, because you need to move the bones. But looking at the different kind of research and how they're showing that it's really promising results affecting the life, and the life is better, the quality of life of the patients. Again, in Slovakia, it's not something that we have in the clinical practice, and that's huge problem for patients. So when we're thinking about the impact of diseases, where we want to get here, the pain, for example, or fatigue, it's something that is well known that we have in this kind of diseases. But a lot of times it's also affecting the anxiety, depression, generally mental health, all the quality of life, even sleep quality. And all this affecting also the social participation or ability actually to participate in a life. Because when I was in the clinic a lot of times with the patients, they was really complaining, and they was telling that, okay, even when weather change, I start to have pain, and now I don't know, my friends will come, that they will come over. I'm terrified of this situation because I am expecting I will have pain. I'm not able to clean the house. I'm not able to go upstairs, take the vacuum cleaner. It's really heavy for me. So even these kind of things actually, in generally, really reducing the participations of the patients. Integrated care, as I mentioned, that's something in Slovakia. We're speaking about it, looking really great, but in the practice, not really happening till now. And especially social prescribing, this was also in the previous presentation, we heard about it. It's something that it's showing really good results. And when we thinking about the older people, that a lot of times are retired home, and the participation is reduced because of that, or we thinking about the patients that they have musculoskeletal disease and they are on disability leave, because I had in RA patients, I had over half of the population that there was on disability leave, they was not able to work anymore. Or a patient, all of them was before surgery, so also they was home. It's really scary thinking about it, for example, because the isolation, as we know, it's even more or higher factor for the mortality than passive smoking. So it's something that we really need to think what we will do about it. So when I look, because the conference is about the age, so I was looking at the factors, physical and also psychosocial, which they are affected in musculoskeletal patients due to the age. As I mentioned, the patients, the osteoarthritis patients was before the surgery. RA patients, actually it's a little bit more or smaller group, because there was on the special biological treatment, so there wasn't on the really treatment that is classical, but when it's not working after they go to biological, so also this reason why there was more older patients there. When I use different kind of the questionnaires and do the statistics, first of all, I just want to point out that age difference was even different between the RA patients that were younger compared to OA patient. Actually, this is one thing that it's positive when we think about the age, because when the doctors are considering the surgery for osteoarthritis patient, the age is a plus there, because when you are older, they are more willing to. In younger patients, a lot of time they postponing the surgery. But when we're looking, they had also the differences in how, for example, common was the other comorbidities, the functional disability, even in the pain. But there was no difference in the sleep quality. It was poor in both, and also physical and mental health. When we was comparing it, there wasn't big difference there. So what on the results actually is different or and age related between the diseases? Looking at the comorbidities, there were more common in RA, but actually with the age, that was connected with just osteoarthritis patients. The functional disability, on the other hand, was the exact the other way. So it was more worse, the condition that osteoarthritis patients have, but the connection with the age was with the rheumatic patients. Maybe due to the surgery, because they have the light at the end of the tunnel that after surgery, their functional possibility or activities that they do, they will restore. The patients with rheumatoid arthritis, they do not have this kind of a chance. So it was really there, similar with the pain, and all nearly other factors was significantly associated with the age. But when we look at the social participation, again, we are on the similar thing. So probably due to the aspect that they are able to have a surgery, so they are able to participate later on more, it wasn't connected the age in osteoarthritis patients, just with the patients that they have rheumatoid arthritis. Actually, I do not have it here in the presentation because I try to, before lunch, keep it short, but I published one of the article of social participation, and we was looking there if it's illness perception mediating the relationship between pain, fatigue, anxiety, depression, and in all of the cases it was really mediating. So when we're thinking about what to change, the illness perception that is going exactly with how they see the disease, how it is explained to them, what kind of non-pharmacological intervention they are able to have, how actually in Slovakia is not working social prescribing at all. This is all the things that need to change to be able to change and the participation and generally the life of the patients. And illness perception is something that is not that hard when we're thinking, for example, about the cognitive behavioral therapy. It's quite easily to be changed, specifically at the beginning of the disease. And it wasn't just social participation. Now I try to, when I'm writing the other paper, actually with the fatigue, and I put the same thing, I put a mediator, the illness perception there, and we see that is a circle that's working also with the fatigue. So it's something that's, it's quite easily to be changed, why we leaving it as it is. Generally, we see that there is age-specific differences that the patients need, and we should focus more, because a lot of times the old people are like, okay, I am old, I am awaiting disease, it happened to me, but there is things how to make their life better is not that hard. So we need to really focus on that, and not just on the physical symptom, because that's another huge problem, especially in Slovakia, that when you go to doctor, you're speaking about the problems that they are physical, and a lot of times you don't speak about the mental health, but that is influencing. It's one vicious circle. So if one is not working well, the other one not too. So we need to also look a little bit more in the detail to that. Thank you very much. That was the references. Thank you.